Hello, Psych community, and welcome to today's webinar, Sleep Disturbances and Depression, Understanding the Relationship to Improve Patient Outcomes. Thank you for joining us today. I am Beth Napoli, a medical science liaison for Otsuka Pharmaceutical Development and Commercialization Incorporated. I'll be serving as the moderator for today's exciting discussion featuring Dr. Jordan Karp, MD, and Dr. Kristine Wilckens, PhD. With that, I'll turn it over to Kristine to tell us more about sleep patterns, architecture, and disturbances.
Thank you. Sleep is vital for an innumerable number of biological, physiological, and psychological processes that affect our health and well-being. Sleep is driven by complex, organized processes. These include sleep drive and the circadian process. Sleep drive is exactly what it sounds like, the drive or pressure to sleep as a function of time spent awake. Looking at the 24-hour sleep-wake cycle, the orange line shown here shows how sleep drive increases the more time that you spend awake, and so your propensity for sleep increases. Then, once you fall asleep, in this case a little after 10 p.m., the sleep drive dissipates as a function of time spent asleep. The biological processes that contribute to sleep drive are in many ways independent of the circadian process, which you see here in light blue. This is the rhythmic propensity for sleep over a 24-hour period. It is controlled by a pacemaker in the brain that is entrained by the light-dark cycle. It is because of the circadian rhythm that you are more likely to be awake when it is light out compared to when it is dark out. And this rhythm is independent of how much sleep you have had recently. Melatonin is one example of the variety of hormones involved in sleep and circadian rhythms. Melatonin is secreted in the brain as a function of the circadian rhythm, as you can see here in dark blue. It is low during the day and increases with dim light around the habitual bedtime and helps to induce sleep. Sleep is best and we function best during the day when we align these processes and they work together. Now that we have an understanding of what drives sleep, let's discuss how we can assess sleep. When assessing sleep, it's very important to get a full assessment of not only sleep time, but multiple components of sleep. This includes the pre-sleep conditions. What kinds of activities are they engaging in prior to bed? Are they falling asleep on the couch in the evening? And is that reducing their sleep drive, leading to more difficulty sleeping once they get out of bed? It's important to assess the bedroom environment. For instance, is there a TV in the bedroom? Do they have a bed partner with a sleep disorder? Or does the patient even have a bed that is cleared off and available to sleep on? Time to bed and time to wake are of course important factors to assess, but determining other factors like the amount of time spent sleeping as a function of the time spent trying to sleep is critical to assess. This is called sleep efficiency. It can tell you how disrupted sleep is, and it is related to many other health factors. So this is why getting a multi-dimensional assessment of the sleep-wake schedule is very important. Assessment of daytime activities can be important for a variety of reasons. Assessment of napping and physical activity can be used to determine if the sleep-wake cycle is normal and that sleepiness is not excessive. Assessment of naps can also be really informative for determining sources of nighttime sleep disruption. So while brief naps earlier in the day are less likely to interfere with nighttime sleep, longer naps closer to the evening can seriously disrupt nighttime sleep. So it is important to know the details about napping behavior. Looking over at the right, these measures can be assessed with questionnaires, which may assess sleep broadly over the past month, for instance. Or you can use sleep diaries, which can be used in which patients take home a diary of sleep and activity questions, and they fill it out in detail each morning and each evening.
Kristine, I'll just jump in and say a couple of things here about what I do in the clinic. So we all screen our patients and ask, how is your sleep? And patients will tell us it's good or bad. But routinely, when I take an explicit sleep history, I do want to know what time they actually go to bed, what time they think they fall asleep, if they're waking up throughout the night, and if it's easy for them to fall back asleep, how much time they estimate being awake throughout the night, what time they wake up in the morning, and what time they actually get out of bed in the morning. And this information is all critical for prescription for better sleep practices that we're going to talk about in a little bit.
Great. We just described how sleep is assessed subjectively with self-report, but we can also assess sleep objectively. The gold standard for sleep assessment is polysomnography, which allows us to determine sleep stages. Humans have multiple stages of sleep that are determined by multiple physiological measures, including brain activity and muscle activity. These measures are used to differentiate rapid eye movement sleep from non-rapid eye movement sleep. Rapid eye movement sleep, or REM sleep, which you see here in orange, is the sleep stage when we are dreaming. Brain activity is similar to what we see during wakefulness, but additionally, there are rapid eye movements and complete loss of muscle tone, which prevents us from acting out our dreams. Non-rapid eye movement sleep progresses from light to deeper stages, the lightest stage being stage N1, and the deepest stage being N3, also called slow wave sleep. Brain activity, also called EEG, gets slower and muscle tone gets lower as you go from stage N1 to N3. All of these stages are important and they interact with one another to support various aspects of health, including psychological health, as we're discussing here. This slide is showing what we call a sleep hypnogram, showing a healthy sleeper progressing through sleep stages, starting at the top left with some time spent in awake before going into stage 1, then stage 2, then spending some time in stage 3, slow wave sleep, before going into lighter stages again, and then into REM sleep. We cycle through these sleep stages several times throughout a normal night of sleep. However, with major depressive disorder, there are several known changes to sleep that occur. First, you see that the time to fall asleep is longer. That's with the awake in the upper left-hand corner. Then you see that time spent in the deepest stage of non-rapid eye movement sleep is shorter. The overall time to get to REM sleep is shortened. That's called REM latency. And then the duration of REM sleep is found to be extended in major depressive disorder. You may also often find increases in number of awakenings after sleep onset in patients with major depressive disorder. So this tells us that sleep behaviors and sleep architecture are significantly altered in major depressive disorder. Sleep disorders are very common. It's estimated that more than 50 million people in the US suffer from a sleep disorder. For this presentation, we are going to be focusing on 2 disorders that are highly prevalent in depression. These are insomnia and obstructive sleep apnea, or OSA. Approximately 10% of the population suffers from insomnia, and 10 to 20% of adults middle-aged or older suffer from obstructive sleep apnea. While these 2 sleep disorders are often co-occurring, it's important to differentiate them from one another, as we will describe in the next slides. Obstructive sleep apnea is a sleep-related breathing disorder. It's characterized by repetitive lapses in breathing and reduced brain oxygenation. This is due to upper airway collapse, meaning the soft tissue gets in the way of breathing. OSA symptoms include snoring, daytime sleepiness, and lapses in breathing. OSA is more prevalent in men than women, and the rates of OSA increase with age, usually due to lengthening of the soft palate. Risk of OSA increases with higher body mass index, potentially due to less muscle tone and soft tissue size, causing more airway blockage. Risk also increases with the use of benzodiazepines, opioids, alcohol, and smoking. It is often comorbid with depression and other conditions. Insomnia, on the other hand, reflects a reduction in sleep ability despite an adequate sleep opportunity. So this is very different from someone who is chronically sleep deprived because they limit their time in bed. Difficulties with sleep onset and sleep maintenance are the main characteristics of insomnia. So for instance, there's evidence that people with insomnia tend to have less than 90% sleep efficiency, meaning that less than 90% of the time spent in bed trying to sleep is actually spent sleeping. And insomnia is often comorbid with depression and other psychiatric disorders. There are self-report measures that can be used to assess these sleep disorders. To assess obstructive sleep apnea, the Stop-Bang questionnaire can be used. This assesses the various symptoms of sleep apnea, including snoring, observed apneas, and risk factors such as high body mass index, large neck circumference, older age, and male sex. It includes 8 yes or no questions with scores ranging from 5 to 8, indicating a high risk for OSA. Treatments for OSA primarily include positive airway pressure to keep the airway open during sleep. This is often used in more severe cases of OSA, and oral appliances may be used in more moderate OSA. It's suggested that behavioral modifications also be included in the treatment plan for OSA to generally reduce the risk for OSA, like behaviors that might help lower body mass index. Jordan, did you want to comment on use of this questionnaire in the clinic?
Sure. We routinely use the Stop-Bang questionnaire. It's a funny name, but it stands for the different items that are assessed. So snoring, tiredness, observed apneas. And even though all practices might not implement the Stop-Bang into their workflow, being aware of these risk factors and symptoms of sleep apnea can be useful in an informed sleep history.
Great, thank you. Because insomnia is a distinct sleep disorder, it is assessed differently from OSA and has different treatment. Insomnia can be assessed with the Insomnia Severity Index. This is a 7-item questionnaire, and total scores ranging from 22 to 28 suggest severe insomnia. There are a variety of effective therapies for insomnia. These include behavioral interventions as well as pharmacological treatments. Pharmacological treatments can include hypnotics, antidepressants, over-the-counter sleep aids. We're not going to discuss these in detail in this presentation, but we are going to talk more about behavioral interventions for insomnia.
Thank you, Kristine. We actually had a question that came in that I think is relevant to this discussion. So the question was, can you address the importance of assessing underlying causes of insomnia?
Thank you. Thank you. That's a great question. And I think that you will find that as we continue to discuss this, that will be elucidated more. But so first of all, I think it can be very difficult to identify what the root underlying cause of insomnia is, and there is debate as to whether that is even necessary. So while known comorbid medical psychiatric issues should definitely be addressed and any issues with the sleep environment should be addressed, I think it's important and informative to know that sleep restriction therapy, which we'll talk about, which is a major component of treatments for insomnia, seems to be fairly robust, and studies have shown improvements in some of the comorbid symptoms that you might think were the cause of the insomnia. So an example of this is with nocturia, which is getting up to use the bathroom in the middle of the night. And this has been shown to decrease with brief behavioral treatment for insomnia, which is one of the behavioral treatments we're going to discuss. And nocturia is not addressed with brief behavioral treatment for insomnia. So while there may be one or more underlying causes, insomnia and the other issues may be mutually exacerbating. So in some instances, treating the insomnia itself can have beneficial effects on both issues. And Dr. Karp will talk more about that in the context of depression.
Thank you, Kristine. Now we'll turn it over to Dr. Karp to discuss the bidirectional relationship between sleep disturbances and depression.
Good, thank you. So I hope that we're convincing you that sleep disturbances are frequently comorbid and mutually exacerbating with a variety of psychiatric and neuropsychiatric conditions. So certainly sleep complaints are frequently described in major depressive disorder and bipolar disorder, in frequently observed anxiety disorders, which are high stress states such as post-traumatic stress disorder and generalized anxiety disorder. In neurodegenerative diseases such as Alzheimer's disease and Parkinson's disease, sleep schedules can become really out of whack. And in advanced Alzheimer's disease, some patients actually have sleep inversion where they are up all night and sleeping throughout the day, which can be especially problematic for caregivers. Finally, we know that chronic pain is worsened by poor sleep, and poor sleep seems to worsen poor chronic pain. So it's a mutually exacerbating condition. So in the psychiatric clinic, approximately 18% of patients who present with major depressive disorder also present with obstructive sleep apnea. And about 90% of patients who present with major depressive disorder also present with insomnia symptoms that are either part of their depressive symptom or syndrome, or perhaps a prodrome. So they develop these insomnia symptoms prior to developing the depressive disorder. So to further drive home this point, we wanted to share the results of this survey with you that really shows how poor sleep and insomnia are significantly related with depression. This is a survey that was published in 2015. There were over 1,100 adults without depression who were assessed at baseline, and then they were followed over the course of 7.5 years to study the incidence of depression. And the incidence of depression for the entire group was 15%, which is somewhat high, but is consistent with some other reports of maybe subsyndromal major depressive disorder. But poor sleep and insomnia, so meeting their criteria for insomnia, were significantly associated with the development of depression over the course of these 7.5 years. And the odds of incident depression or new onset depressive syndromes was highest in patients who had, or individuals who had insomnia with objective short sleep duration. The persistence or the worsening of poor sleep and developing into insomnia was the most significant predictors of incident depression.